I will give a longer introduction, and a little background for Dr. Robert Dubois, who is the Chief Science Officer and Executive Vice President. It always throws me when people have two titles, for the National Pharmaceutical Council. And Bobby's career actually is varied, like my own. He was also an internist by training, graduated from Johns Hopkins Medical School, but then moved into areas more related to policy and quality. Founded several institutions that were instrumental in developing measures and research to assess quality and to guide policy. And at NPC, his role is overseeing the research efforts and the focus, again, on comparative effectiveness research, quality, and the implementation of those ideas in real world in the healthcare system. And like all the other panelists, Bobby is widely published in these areas, and again, an excellent person to provide a perspective on practical value in our healthcare system. So, Bobby, welcome you to the podium.
Thank you very much. You've done a tremendous job as a stand-in. That's very impressive with a couple of hours' notice to do all that you've done and share the perspective that you had. So I appreciate you're doing that. So Darius provided some important economic framing principles to how to think about this. So I'd like to now take it the next step and talk about how are people actually measuring value in the United States today. And I want to make 3 points. First, there's a lot of groups out there doing it, and they're all doing it differently, which might be a good thing or a bad thing. Second point I want to make is that as you look at these frameworks that are out there that are being used, there's a lot of things to be worried about. There's some things to be happy about, but there's more things probably to be worried about. And the third piece of the puzzle is actually you can develop guiding practices or principles so that the frameworks in the future actually are the type of frameworks we would be very happy to have used to evaluate value. So there are things to worry about and things to be happy about. And I do not work at the Schaefer Center. Okay, so the first point is there are a variety of groups out there developing ways to measure value. And I'm going to touch upon a few that are in the cancer space, but there are a number that are in the non-space as well. Some of these are professional societies, American Society for Clinical Oncology, NCCN, National Comprehensive Cancer Centers. Some of these are sort of payer-oriented or connected, the Institute for Clinical and Economic Review. There are other payers, Premier is another one. So there's a lot of groups out there who have said, we are worried about the rising costs of healthcare. Very quickly they go to the rising prices of drugs, and even more quickly then say, we must measure the value of drugs. They're not taking the same lens to all other aspects of healthcare. That, of course, is one of the guiding practices. You need to look everywhere. So they have been sprouting up. Some of them have gotten a lot of traction, some have not. And so I want to sort of walk through a few to give you a flavor for how people are doing this. And they likely don't comport with some of the points that Darius raised, which is sort of a patient centricity issue. So ASCO has a clinical framework they came out with a year or so ago to look at cancer drugs. Now, on the surface, it looks like they're doing the right thing. They have a measure that looks at clinical benefit. They have a measure that looks at toxicity. Somehow or other, they come up with, you get 80 points for one and 20 points for the other. And somehow they came up with, you add those up. You don't divide them, you don't multiply them. And there's no rhyme or reason for why one is 80 points and the other is 20 points. And how they came up with this formula. That is a real area of concern. Plus, they have a very narrow way of thinking about value. They're not thinking about quality of life, caregiver burden, ability to function and work. So this is sort of one example that's out there. And if you're in the world of evidence-based medicine, when you think about benefit, you think, well, I think I'll bring all the articles together that bear on the benefit of a drug. There may be a lot of articles, there may be very few articles. ASCO made a decision that they're just going to choose one article, what they deem as the best article, and that's how they will measure value. So there's a lot of things to be concerned about. The concept of measuring value is wonderful, the execution is worrisome. All right, the next group, and this is the one that's gotten the greatest traction. You saw it in the slide that Martin shared with us. So the Institute for Clinical and Economic Review has a way of thinking about value that on the surface looks pretty good. They have many factors they think about. So there's a cost per quality or cost per year of life element to it, but they also think about unmet medical needs. They think about patients who don't respond to therapies where a new therapy would be very beneficial. So they think more broadly about value than the ASCO group. So that's a really good thing. They also do something that's is quite interesting, which you may think is a good idea or you may think is a bad idea. They work backwards and figure out what the price of the drug should be. So basically they say, what is the cost, the price of the drug? I wander. What is the price of the drug? What should the price of the drug be to achieve a cost per quality, a cost per year of life that is within a range that they deem acceptable, $100,000 to $150,000. So they come out and say, well, the price of the drug, list price is this, but the price really should be something much lower. So when they came and looked at the new cholesterol drugs, they said, well, the prices are $14,000, but really it should be about half that. They also do something that's very interesting. They look at the budget impact of the drug. So they take, in essence, the number of people that are likely to use the drug, they multiply it by the price, and they come up with a certain number. And then they say, well, is that amount of money to spend on hepatitis C therapy or a new cancer drug, is that the right amount for society to spend? And so they come up with a formula that basically takes the rise in GDP, times health spending, times the percentage of health spending that's due to drugs, divided by 34, which is the number of new drugs that come out per year, and basically come up with the formula that nets down to $934 million. So if this drug is going to cost more than $934 million society-wise, then it's too expensive, and therefore the drug company should drop the price. So another kind of interesting way of thinking about these things. Not one that we would support, but an interesting way. So a third way that folks have gone about this is a group at Memorial Sloan Kettering. The good news is they have many different factors that go into the value equation. Another wonderful piece of their puzzle is they allow each person to weight each factor. So if you think the rarity of the disease is important and the drugs need to be focused on that, you raise that slider bar up. If you think toxicity is less important and survival benefits more important, you would adjust things accordingly. So what's really nice about this approach is that it allows users to dial up and down what factors are more or less important for them. So that's a very good feature, and it's only seen in this value approach. We don't see it in the other ones. All right, so that's the first piece of the puzzle. A lot of folks are doing this. Now, as we step back and look at all of these, there are some areas of concern that we've listed here. We've got a lot more of areas of concern. What evidence you choose to include is very important, and the way you select that evidence is not so clear and needs to be very clear. None of these models are transparent. They're all black boxes in one way or another. You can't play with them. You can't take their economic models and say, now, what numbers did you use? And if I put in different numbers, would I come up with something different? So lack of transparency is a really big deal. And just like I mentioned with the formula used by ASCO, like, how did they come up with this? So the validity of each of these approaches really has not been tested to tell us that, in fact, it was done right. So these are very important issues of concern. Now, when you have an area of concern, what do you do about it? So we've started a process, which we hope will be a public dialogue, of coming up with guiding practices. So if you want to develop frameworks for value properly, what are some of the principles or practices that you should use? And there's about 35 of them that we've come up with, and these are some of them here. You know, you shouldn't just focus on drugs. You should evaluate all aspects of healthcare. You need to have patients at the table. You need to have industry at the table. You need to have payers at the table. You can't have a framework that only thinks about it and only includes one set of people. You need to think much longer horizon than what a typical insurance company would focus on, which might be a couple of years. You need to think about the lifetime of the benefits and the lifetime of the costs, so on and so forth. So there are ways that this can be done that would be productive. And so what we hope we will have now, is we're going to be going public with these in about 2 weeks' time, is to begin a public dialogue, starting with the principle that we want to evaluate value. As Darius said, the price has to be in some connection to the benefits, and so value is very important, but we need to do it right, because the systems that I've shared with you are nice steps in a proper direction, but they're not ready for prime time. So let me just sum up by saying everybody's in the value game, and there will be more out there doing it. Nobody's ready for prime time. There are areas of deep concern about each one of them, but we can move the field forward if we can agree upon what the principles and approaches should be, and encourage the framework developers to use those as they refine them. And I'll be happy to take questions as we get into the Q&A later.
Great. Thank you very much, Bobby.